Revati, hi.
Hi.
Revati sitting in Alvinda. Good.
Good evening, ma'am.
राजेश बॉस पहले आप वेलकम कीजिएगा.
Good evening, Satyajit. Hi, Rajesh.
Hi, Anand.
Good evening.
Different.
So we are live.
Okay. So, very good evening to all of you. I welcome you all on behalf of the Indian Society of Corneal and Keratorefractive Surgeons and the Bihar Ophthalmological Society in this wonderful webinar on common corneal problems and how to handle these. To begin with, I'll request Dr. Satyajit Sinha to start the introduction, please.
Okay, കുഴപ്പമില്ല.
A very good evening and a very warm welcome to everybody. We are very blessed to have with us Professor Jeevan S. Titiyal sir, who is the president of ISC KRS. He is the professor and head of cataract, cornea and refractive surgery services at RP Center in AIMS. He has numerous publications and he has huge experience in the field of cataract, cornea and refractive surgery. Sir needs no introduction. Sir is already known to all the ophthalmologists around the country, but it's our duty to read this out. He has received many awards, including Achievement and Senior Achievement Award at the American Academy of Ophthalmology, and he has received the most coveted Padma Shri from the Government of India by the President of India. A very warm welcome to you, Professor Titiyal, sir.
Next. It's a matter of great pleasure and honor for me to welcome the President of Bihar Ophthalmological Society, Dr. Milind Kumar, who has contributed immensely to our society, to Bihar Ophthalmological Society, and also at the national level in various capacities, starting as a member to joint secretary, and now currently is the President of Bihar Ophthalmological Society. He is an awardee, has received various awards, but the prestigious D.K. Bose Gold Medal Award is something which stands out. He is also winner of Dr. Ram Gold Medal at the Kosi Ophthalmological Society Annual Conference. He was trained at Rohtak, PGI Rohtak, and then he went on to have various trainings in various places. He is a very active academician. We would like to welcome you, sir.
A very warm welcome to Dr. Rishi Mohan. He has done his 5 months training clinical researchship in FECO from Prince Charles Eye Unit at King Edward 7th Hospital from Windsor in UK in 1994, and he has received the Best Resident Award from Dr. RP Center of Ophthalmic Sciences. He has held the positions of Member Managing Committee of AIUS, Member Scientific Committee in AIUS. He was the Secretary of the Indian Society for Cornea and Keratorefractive Surgery, and he was the Treasurer of the Eye Bank Association of India. He was also the Joint Secretary, and he was the President of Delhi Ophthalmic Society, and he was the Vice President of ISCRIS from 2016 to 21. A very warm welcome to Dr. Rishi Mohan.
Dear friend, Dr. Vibhuti P. Sinha, it's great joy and great pleasure for me to welcome him in this webinar. He is currently the Secretary of Bihar Ophthalmological Society, and he's also the head of the Department of RIO IGIMS Patna. He's an excellent teacher, clinician, surgeon, and administrator. He's actively involved in academics. I have seen him very closely. He is 24/7 involved in academics and building up the infrastructure at the RIO IGMS Patna. A true leader and a very dynamic person. We welcome you, Dr. Vibhuti.
We are very blessed today to have the Secretary of All India Ophthalmic Society, Professor Namrata Sharma, with us. She is the Professor of Ophthalmology in Cornea, Cataract and Refractive Services at Dr. RP Center for Ophthalmic Sciences. Her notable affiliations are she is the Regional Secretary for Asia Pacific Academy of Ophthalmology, and she is the Secretary for AIUS, as I said. She is the Secretary for Eye Bank Association of India, She is the chairperson, Scientific Committee of Indian Society for Cornea and Keratorefractive Surgery. She has more than 380 publications in various journals, 19 book chapters, has authored 11 books. She is actively involved in the teaching of undergraduate as well as postgraduate in various teaching programs, and has been conducting numerous instruction courses and has been invited faculty at various national and international conferences. A very, very warm welcome to Professor Navratna Sharma to this webinar.
We also have with us our dear friend, Dr. Rajiv Mukherjee, who is the treasurer of Indian Society of Corneal and Keratorefractive Surgeons. He is the vice chairman of Family Benefit Scheme of AIOS as well. He is director and senior consultant at Mukherjee Eye Clinics and also a visiting professor at Feinberg School of Medicine, Northwestern University, Chicago, USA. A very good academician and a very good reader of corneal mapping. We welcome Dr. Rajiv Mukherjee in this webinar.
We have with us Dr. Krishna Prasad Kudlu with us, who is the chairman of Prasad Netralaya Group of Hospitals in Udupi. He is the secretary of Karnataka Ophthalmic Society presently. He is the member of the Scientific Committee of All India Ophthalmological Society and is actively involved in academics both nationally and internationally. And he is especially known for his work in Press Beyond. A very warm welcome to Dr. Krishna Prasad Kudlu.
I'm really pleased to welcome Dr. Rakhi Kushmesh, who has been trained at RP Center as a senior resident, and currently she is working as additional professor at RIO IGMS Patna. She has now extensive work experience in keratoplasty, limbal stem transplantation, and ocular surface disorders. She has authored over 20 index publications and has many chapters in textbooks to her credit. So we welcome Dr. Rakhi Kushmesh.
A very warm welcome to Dr. Prabhakar Singh, who has done his MD ophthalmology from Dr. RP Center, AIMS, New Delhi. He's a cornea and he did his cornea and anterior segment fellowship from LV Prasad Institute, Hyderabad, and is currently working as a senior resident at AIMS, Patna. We are looking forward to hearing his talk. A very warm welcome to Dr. Prabhakar Singh.
We also welcome Dr. Pranav Ranjan, who is currently the secretary of ISOC. He is also the president-elect Bihar Ophthalmological Society. He is always very enthusiastic in academic activities at state and national level, and is always full of it's a matter of great pride for us to have Dr. Pranav Ranjan in this webinar.
A very warm welcome to Dr. Deepak Kumar, who did his MS in 1983 from Ranchi. He was the joint secretary of Bihar Ophthalmic Society in 1981 and 84-86. He was the organizing secretary for 33rd BOSCON. He was the member of the ARC Central Zone from 2005 to 8, and he was the president of the Varanasi Ophthalmic Society in 2018. He has made several presentations in BOSCON, ISOC, and AIOS. A very warm welcome to you, Dr. Deepak Kumar, sir.
It's my pleasure to introduce Dr. Gautam Kumar, who has done his MS from Patna Medical College and also senior residency from RIO IGMS Patna. He has worked as consultant eye surgeon at Rajendra Nagar Hospital, Patna, presently working in PMCH Patna, and consultant Narayan Netralaya and Research Center, Patna. So we welcome Dr. Gautam Kumar.
A very warm welcome to Dr. Ajay Sinha. He is the assistant professor at Patna Medical College Hospital, Patna, and formerly he was the treasurer of Bihar Ophthalmic Society. A very warm welcome to you, sir.
We also welcome a dear friend, Dr. Nilesh Mohan, who is presently working as additional professor and in charge of Eye Bank of Bihar at RIO, as well as serving as treasurer of Bihar Ophthalmological Society, secretary of Patna Ophthalmological Society, member E-Zone EBAI, and immediate past editor, Bihar Journal of Ophthalmology. He has got his postgraduate training at RP Center and senior residency at RIO Patna. He has a huge experience after post-graduation, and he has been a pioneer in establishing the eye banking in the state of Bihar at RIO IGMS in 2014. And he had the privilege of performing the first corneal transplant surgery in Bihar in October 2014, and has been credited with many publications in national and international journals. And apart from that, he's a very good singer. We welcome Dr. Nilesh.
A very warm welcome to Dr. Praful Kumar Maharana. He did his MD senior residency from RP Center in AIMS, New Delhi. He worked as assistant professor at RP Center, AIMS, New Delhi. He has experience of working as faculty at LVP, AIMS Bhopal and AIMS Bhubaneswar. He is the editor of Ophthalmology Clinic book series and he's published more than 100 PubMed indexed papers. He is the assistant editor for Indian Journal of Ophthalmology and he's also the editor for Delhi Ophthalmic Society Times, DOS Times. A very warm welcome to you, Dr. Prafulla.
We welcome Dr. Gautam Singh Parmar, who is head of cornea and refractive surgery services at Sadhguru Netra Chikitsalaya, Chitrakoot. He has his expertise in cataract, cornea, and refractive surgeries, and has published in peer-reviewed journals, including the stenciling-based prick and print technique for harvesting shaped corneal grafts. He has received many awards, notable among which is Young Achiever Award by Iskeres and the Best Video Award for Stenciling in Ophthalmology in Jam Session, Keracon 2017. We welcome Dr. Gautam Singh Parmar.
A very warm welcome to Dr. R. Revati. She is heading the Cornea and Refractive Services at Arvind Eye Hospital, Coimbatore. She has received MBBS from Tanjavur Medical College, Madras University in 1985. She did her MS Ophthalmology from Stanley Medical College. She did her fellowship in cornea under Dr. M. Srinivasan in Arvind Eye Hospital in 1994. She started the cornea services and the Arvind IOB Eye Bank in Arvind Eye Hospital, Coimbatore in 1997. She has over 60 publications in peer-reviewed national and international journals, and she has published 6 book chapters. A very warm welcome to Dr. Revati.
We also welcome Dr. Mamta Singh, who is working as a senior resident at PMCH Patna. She has been a fellow of surgery services. Admin, can we mute all of this? She is also the editor proceedings of Bihar Ophthalmological Society, and she is member editorial board ISOC. We welcome Dr. Mamta Singh.
A very warm welcome to Dr. Anand Parthasarthi. He is the chief surgeon of Center for Vision Eye Surgery at Chennai. He has 3 fellowships in refractive surgery, cataract and cornea at the University of Erlangen under Professor Claus, Germany, Singapore National Eye Center, Singapore, and under Professor Donald Tang, and under Dr. Nagrao at LV Prasad Eye Institute, Hyderabad. He has many awards to his credit. He was awarded the Best Poster Award at the American Academy of Ophthalmology in 2007. He has received the C.P. Gupta Award. He has also received the E.T. Selvam Tamil Nadu Ophthalmic Association Postgraduate Award in 2001. He has presented in various national and international conferences and has over 35 publications. A very warm welcome to you, Dr. Anand Parthasarthi.
It's a matter of great pleasure for me to have my co-moderator, Dr. Satyajit Sinha, who is the Chairman Scientific Committee of Bihar Ophthalmological Society. He is the Director of ABI Institute at Patna, and he is also the ARC East Zone member of AIOS. He is section editor of IGO, and he is the recipient of several awards, including Dr. D.K. Bose Gold Medal and IRSI Gold Medal. He has been actively involved in academics throughout, both nationally and at state level and even internationally. So for me, it's a matter of great pleasure to have him as a co-moderator.
It's an equal honor and privilege to welcome the Treasurer of All India Ophthalmic Society, Professor Rajesh Sinha. Professor Rajesh Sinha is a professor of ophthalmology in cornea, lens and refractive surgery services at RP Center. He has done MD Ophthalm from AIMS and then DNB, FIA, CLE and FRCS, and did a fellowship at the University of Washington. He has 354 publications, 4 textbooks and 5 educational manuals to his name. He has been a part of 3 multicentric FDA clinical trials. He has received various awards, notable among which are Achievement Award of AO, APO and SARC Academy of Ophthalmology, and has been appointed the Professor of Asia Pacific Academy of Professors in Ophthalmology. He is the recipient of many notable orations in the country. Currently the Treasurer of AIOS, Treasurer of SARC Academy of Ophthalmology, General Secretary of Indian Society of Cornea and Refractive Surgeons, and Treasurer of iBank Association of India. A very warm welcome to Professor Rajesh Sinha to this webinar.
Thank you, Dr. Satyajit, for the kind words. And before we start the scientific proceedings, I'll request the President of ISCRS, Professor J.S. Titial, to speak a few words. Sir, please.
Thank you, Dr. Rajesh. I would definitely like to welcome the people who have joined us today for this very, very important session on common corneal problems. I think this is not only for corneal surgeons, it is for everybody. The type of issues and the topics selected are wonderful. And we had a long session on introduction. I can't have a discussion on that, but I can summarize the entire gamut of people sitting here. We have a huge experience of experienced people that will really help us in our panel discussion. And I see the young people going to make a lively presentation. So it's a beautiful mix of people, and I really congratulate BOS organization and ISCRS. I'm very thankful to Satyajit Sinha for giving me this honor to chair this very important session. And I wish people who have joined us today, they'll benefit from this very, very common corneal problem which we face every day. And sometimes the solution can be tricky. But if done properly, it can be very, very fruitful for our patients who have chronic problems. So wish you all the best for a session and discussion. Let's go with the session now.
Thank you, sir. Before we actually go into the session, we would just like to have Dr. Vibhuti, who is representing the president of BOSS today, is the secretary of BOSS, to speak a few words. Dr. Vibhuti, please.
Just want to say welcome, sir, welcome Titial, sir, welcome Rajesh, sir, welcome Namrata ma'am, Rishi Mohan, sir, and everyone. I know ICKRS is very important for Bihar Ophthalmological Society. They're actively involved in propagating and actually strengthening the cornea services in the state of Bihar. So welcome everyone, and we move on to the scientific session now. Thank you, sir.
Thank you. Thank you, Dr. Vibhuti. And now we move on to the first talk, and that will be done by Dr. Nilesh Mohan, who will be talking on acute chemical burn, first aid. Dr. Nilesh Mohan, please.
Am I audible, please?
You are audible.
Yeah, you're audible.
Yeah.
You just share your screen. Yeah.
So, good evening, everyone.
Slideshow.
Yeah. Good evening, everyone. And at the outset, I would really thank ISCRS and the Bihar Ophthalmic Society for giving me the opportunity to share a few things. I have been assigned the topic of acute chemical injury, though the topic is too vast and too exhaustive, and each individual topic becomes a topic of seminar. But I have been assigned to go in with the first aid part, which later on affects the prognosis in these kind of patients. So moving into chemical injuries, different series have said that there is around 8 to 18% occurrence of these kind of chemical injuries in our clinical practice. And as we all know, alkali injuries are usually more common. And it's more oftenly seen that the young males are at more risk because they are more face the occupational hazards. And the agents which are usually involved is either a domestic one, or whether they are in an agricultural environment, or whether they are in an industrial environment. The injury types can be in the form of the solid form of the chemical, or the liquids or the vapors. So all the kinds of forms can inflict the eye and cause damage to the eye. We all know that the alkali penetration is very rapid, so the alkali burns are more serious and needs attention urgently. So when we are dealing with the chemical injury, at least the common things we have to keep in mind, what are the sources and what actually is the pH. Though we have a chemical injury and we move ahead fast to the management. So just we have to look into this slide a little bit cautiously, that these are the fertilizers, refrigerants, and the cleaning agents. These have a very high pH value. This caustic soda or the drain cleaners used in households, these have a very rapid penetration, have a very high pH, and cause a very rapid penetration. Firework injury is very common in children. These have a combined thermal burns as well as a penetrating injury. So they have a pH of 10.5. So I just wanted to emphasize that we have to keep in mind that the common agents which we encounter and what is the pH level and how much damage it can proceed with. Similarly, we have the common acids, battery injury, some blasts. So we need to know a little bit, though it would be some kind of a revision for all of us, but we have to recall it that yes, among the acids, this hydrofluoric acid is very damaging because its penetration is too high. As we all know that usually the injury caused by the acids cause coagulation of proteins and the penetration is limited. So they cause less severe injury. But yes, the stronger acids are equally damaging as alkali burns. So here also you need to keep in mind the pH of these acids. In all the cases, we have to neutralize it to the pH of the eye, which is around 7 when we are treating the patients. So what are the factors that affect the outcome? I pointed out that the pH value becomes important, which chemical has been inflicted, the temperature of the chemical, the impact force, the amount and concentration which has been instilled in the eye, and definitely the dissociation coefficient, redox potential, specific reactivity of the particular chemical, which causes ionizing effects and the damaging effects in the stroma. So these are the factors which really affect the outcome when the injury has occurred. So these must be kept in mind. I'll just quickly go into because the classifications, because before going to the first aid part, you have to assess based upon these things. The classification of ocular surface burns classically by Roper Hall was based upon corneal epithelial damage and the limbal ischemia, where we had a good prognosis in the first 2 grades and very poor prognosis in the 4th stage. The latest classification, which has been modified by Dua, where the conjunctival involvement has also been taken into consideration, where the clock hours of limbal involvement as well as the conjunctival involvement, usually the prognosis is considered by both of them. Here you have good prognosis even up to grade 4. So assessment of conjunctiva and limbal involvement becomes important when you are dealing with a chemical injury. Now, what is the emergency first aid? What is the objective behind it? What we want to do is to minimize the ingress of the chemical agent into the anterior chamber to minimize the damage. We want to remove the potential reservoir, if at all is there, to prevent the ongoing injury. So you do that by neutralizing the pH because the chemical agents will act at their own pH. You want to reduce the inflammation which has occurred, and you definitely want to prevent the long-term sequelae. Now, initial assessment must be done at the point where the patient is presented. The treatment must begin immediately at the time and at the place of injury, or even if the patient is being transported, that should continue. Otherwise, the damage will be ongoing. So prompt and prolonged irrigation until the pH of the ocular surface has normalized between the range of 7 or 7.2. If you do not have the pH indicator to measure it, at least a prolonged irrigation definitely helps it out. And removal of residual debris by swab becomes very, very important. So once the pH has been neutralized reliably, then a complete ophthalmic examination is to be done mandatorily to characterize what is the extent of the injury, and then the treatment is planned accordingly. Now, at this juncture, I would like to just share a small video which would be, I think, of quite benefit to all of us who are doing it. I have just picked up this is just how to move ahead with the eye wash. When the patient presents to you, with a chemical injury. I have just picked up this video from the YouTube. It was a very nice informative video. You assess the pH. Now, before doing the wash, you have to instill topical anesthetic for the cooperation of the patient. And then, as I pointed out, that a gentle debridement of all the residual contents in the inferior fornix while asking the patient to look up. Then again, you have to invert the upper eyelid and then again gently swab it with your swab sticks, sterile swab sticks, so that all the contents which all are there can be removed. Now for a wash, you can very well use the BSS or a normal saline or ringer lactate, put in a kidney tray on the side and put a swab in the ear so that it doesn't go into inside. And again, put the topical anesthetic, and with a IV set, you have this is not a big deal to do for anyone who is doing a clinical practice in a remote place also. A continuous irrigation constantly has to be done. Lower fornix has to be properly washed while asking the patient to look up, and the upper fornix is to be cleaned while asking the patient to look down. Again, the lids must be everted, and after you have even done the debridement with your swab sticks, you should wash it thoroughly. Later on again, if you have the pH paper, you can do it. So the important steps would be the first assessment of the pH. The second is installation of the anesthetic drops. Third would be the debridement, and then do a proper wash reaching up to the fornices. Now this double eversion of the eyelids become very important to go into deep into the fornices. Using of Desmere's retractor while retracting the upper lid helps you to remove that. And then again, you can pull up the Desmere's even up more and reach out into the fornices to remove the remnant particles, mostly occurring in the Lyme injuries where we have particulate debris. Even if you have done a wash and then later on that causes conjunctival scarring. So after you have done these things, these are very small and subtle things which are so important for the long-term outcome. When you have completed all these things, then you do the assessment of the visual acuity and all the other parameters and grade the injury in which category does it lie. And thereafter, you start off, initiate the treatment. And the treatment parameters in different grades of chemical injury are different, which has been divided into, I would not go into the full details of the surgical parts. So initiating the early phase is so important that you have use of preservative-free antibiotics, copious lubricants, and use of corticosteroids becomes very important in the first 2 weeks of injury. Ascorbic acid drops, if not available, must be given orally into the tune of 1,000 milligrams 4 times a day. 10% citrate drops. These two become very important in collagen synthesis. The destruction of keratocytes have occurred during the chemical injury. So these drugs are very important in the initial phase. Supportive drugs like cycloplegics and doxycyclines, they have also been known to have anticollagenous activity. Now, in the initial phase, the follow-up of the patient becomes very important. I mean, with patients with moderate or even severe chemical injury should be seen on a daily basis to assess the epithelial healing, whether there is any corneal stromal melting or not, or any progressive melting is occurring or not. Frequent follow-up becomes more important till you are using corticosteroids. It is safe to use it within first 2 weeks because later on the collagenase activity increases, and thereby if you have to use steroids, you have to be very judicious because that can even cause a melting if the tendency is there. Once the epithelial healing proceeds satisfactorily, then you can increase the interval of follow-up. Since we have a plethora of blinding sequelae of the chemical injuries, right from the lid part like ectropion, entropion, lipophthalmos, loss of goblet cells, or to the corneal and conjunctival damage leading to melting, corneal opacity, limbal stem cell deficiencies, non-healing epithelial defects, super added infections, microbial keratitis. So you have a plethora of sequelae of the chemical injuries, whatever be the chemical agent. The initial management at the point where the patient has presented, the first aid becomes very, very important to reduce these potential chemical, sequelae of the chemical injuries which happen, which can even restrict to go and resort to surgical maneuvers. So I would say the key takeaways would be that the chemical injuries really are the true emergencies, and the treatment must commence immediately rather than a referral. Even if it is a referral, I would say that the initial wash part should be also continued during the transit period. Removal of particulate matter, which I pointed out was important. Delayed treatment results in penetration into the anterior chamber, and then further difficult situations may arise. As we all know, that strong acids and alkali both are equally destructive, so we cannot ignore that the acids are less damaging. And these initial treatments like antibiotics, steroids, citrate, and ascorbate, which I mentioned, is of paramount importance. And since you have taken care of the initial management, then yes, the rehabilitative surgery becomes less required. And if at all required, should be done when the inflammation has subsided to the level that you can go in for any rehabilitative surgery. Thank you.
Thank you, Dr. Nilesh. It was a very nice and crisp presentation on the chemical injury and what all we should do as far as the first aid is concerned. We will have the questions after the second talk, and I would like to invite Dr. Praful Kumar Maharaj,
Audible,
who will be talking on corneal scraping and keratitis, what all you should know about it. Yeah, Dr. Praful, we can see your slides.
Good evening, everyone. Thank you, boss and Iskas, for allowing me this to take this important topic. So my topic is corneal scraping in keratitis, what all one should know. So what all you should know, I will cover this in three headings: why we do corneal scraping and how to do it, and when one should go for corneal scraping. Why we do it, largely most of us know this, because if you know the diagnosis, you can start appropriate class of antimicrobial agent, and you can avoid use of unnecessary, ineffective, and potentially toxic drugs. The second advantage is, if you are a clinician treating and you know the diagnosis, then you are confident enough to start your treatment. Thirdly, culture allow you to test for antibiotic sensitivity test, so you know the organism is sensitive to which drugs. And informed treatment, we all have heard about informed consent. About few years down the line, there will be this concept informed treatment. The patient or their attendant may ask you, why are you giving this antibiotic, why not this one? So if you have a microbial diagnosis, then you can confidently say, this is the reason why I am treating in this line. And lastly, we know if it is a fungal keratitis, the prognosis is poor compared to bacterial keratitis. So to prognosticate the case also, you need a microbiological diagnosis. So how to do it? There are few aspects which I'll cover one by one. First is timing. If you're the primary contact physician, before starting the empirical therapy, you should go for this corneal scraping. However, in setups like RP center or any medical college, this you may not be the first contact physician. So in those cases, if the patient is already on some antibacterial agent, then you should stop all those antimicrobial for 24 hours. Then you should go for corneal scraping. This will maximize your culture outcome. Consent, if you go through the recent guideline on informed consent for corneal scraping, as such you don't need any written informed consent, but verbally you should take consent and explain the procedure to the patient. Anesthesia, most of the cases can be done with topical anesthesia only. However, if it is a pediatric patient, or if it is a mentally challenged patient, or the patient is very uncooperative, then you should go opt for general anesthesia. Topical anesthesia, we prefer topical 0.5% proparacaine drop here, because this is the least bactericidal among all the topical anesthesia available. Setup, preferably it should be done in under slit lamp. But if you expect that there is a severe corneal thinning and you may land up in some complication, which is corneal perforation, which may occur very rarely, then ideally you should take the patient to operation theater and do it under operating microscope. But remember, whichever is the setup you choose, but it has to be a sterile procedure, and COVID is still there. So you should take all precautions to avoid getting contaminated with COVID. Instrument, there is a controversy about whether to use your Kimura spatula or a 15-degree blade with BP handle or a 26 gauge needle. If we theoretically compare these two methods or these three methods, the chances of getting a good yield of sample as well as safety is better with Kimura spatula or BP handle. But needle offers you advantage of being disposable. You can use one needle for each scraping, and in case of Kimura spatula you have to sterilize the instrument after each procedure. So that is the advantage needle gives to you. At our center currently we are doing a ICMR sponsored trial where we are comparing these two methods, and although I cannot tell you the final result, the initial result suggests both are good enough for microbiological yield. But the major difference is how the examiner or whoever the technician who is doing the procedure, he is little bit apprehensive while using a needle because of the sharp tip. There is likely that you may land up in corneal perforation. Other than that, there is no difference between the two procedure. This is a short video courtesy one of my senior resident, Dr. Sohini Mandal, how to proceed with that. So first you have to explain to the patient about what you are going to do, or else the patient may move or shift while doing the procedure midway. And remember, after putting topical anesthesia, you have to put a speculum, which is very difficult at times because the patient is having photophobia, there is pain, and also the cornea may be a little bit thinned out. So you have to be extra careful while putting the speculum. But as you do more and more procedure, you know how to handle such situation. So once you put the speculum, then you can ask the patient to sit comfortably and do the procedure. In here, if you notice carefully, see, we are using a Kimura spatula for using this corneal scraping. So you can see the this is the Kimura spatula. So once the patient is seated comfortably, the next most important thing to remember is, any corneal ulcer is associated with tissue necrosis and sloughing. And this tissue necrotic part, they contain only inflammatory cell. So you have to clean the eye of all the mucus plugs and all this necrotic stuff before proceeding for a proper corneal scraping. And three things you should remember when you are scraping the cornea: it has to be repeated unidirectional movement. Don't move your instrument all around. Just it has to be unidirectional, and take scraping from both edge and ulcer base. This is a short clip, as you can see. It's from edge to ulcer base, and it's a unidirectional movement. The surgeon is not doing from edge to ulcer base and again from base to ulcer. Once you obtain the sample, the next task is to inoculate it on slides. Always pre-mark the slide where you are going to put your specimen, and always write down the name of the patient, because if the load is high, then there is chances of misplacement of the specimen. The second thing is culture. If you have set up, you can go for direct plating. Direct plating gives you better result. If you don't have direct plating or microbiology setup at your setup, then you can use transport media like Sabbro-Duxtus agar or nutrient agar. But whatever may be the media that you use, you have to remember one thing: you have to avoid contamination while transferring the specimen. If you are using a 26 gauge needle, you can directly put the needle into this transport medium. But if you are using a spatula or a BP handle with 15-degree blade, then you have to avoid coming in contact with any part of the slit lamp or eyelid or your eyelashes. If you do that, then there is a highly likely that the sample will be contaminated. What are the common mistakes? I have already enumerated this. Don't consider this as an procedure where sepsis hasn't to be maintained. So it has to be absolutely sterile procedure. So wear gloves and don't do multidirectional scraping. If you do multidirectional scraping, then highly likely that you will end up in corneal thinning. not cleaning the eye. If you don't clean the eye, it's highly likely that you will not get any microbe, rather you will simply get inflammatory cells in the result. And not explaining to the patient. You have to explain to the patient what you are going to do. If you don't explain midway between the procedure, the patient will go back and move his head, then you will have a lot of difficulty. And as I said, you have to avoid contamination of the sample. Complication, rarely corneal perforation may be there. You have to be prepared for that. If you do routinely such procedure, I would advise you have to have some access to cyanoacrylate glue so that immediately you can seal it. Increase in epithelial defect will be there in most cases, but that is nothing to worry about. Now the last part, or this is the debatable part, which cases need corneal scraping? If one asks me, I'm a corneal surgeon sitting at RP center with a good microbiology setup, my answer will be yes, go for corneal scraping in all cases of infective keratitis. But somebody who is a general ophthalmologist sitting in periphery, then it may not be feasible for that person to go for cornea scraping in all the cases. So this is a debatable issue. Still, we don't have a clear-cut answer, but this is a very good review article by Mosufar et al. About the clinical utility of corneal scraping in infective keratitis. I would just highlight few of the negative point about corneal scraping. Positive point I have already discussed in my first slide, why we do it. So Mossel et al. They highlighted that the sensitivity of both microscopy as well as culture is not 100%. If you notice this table, they pulled the data of 20 largest series on this important topic, and they found out that for bacterial keratitis, the sensitivity of microscopy is 57 to 67%. For fungal, it is better, 68 to 99%. This 99% figure is from one of the study from our South India, where it was almost 98 to 99% the sensitivity was. For culture, as you can see, for bacterial keratitis is around 60%, and for fungal keratitis ranges between 25 to 50%. So even if you go for microbiology, it's likely that you may miss the exact diagnosis in 50% of the cases. Secondly, it's a huge financial burden. Everybody cannot afford a microbiology lab. The cost of the reagents that is used, the cost of the media, the cost of the transporting media, everything is costly here. And in Indian setup, the one important part is lack of technician. You need trained technician who can interpret the result of your smear or culture accurately. So this part is difficult in Indian setup. Usefulness, although we go for antibiotic sensitivity test, but the problem is that whatever MIC or minimum inhibitory concentration that is there, that is based on the achievable concentration of the drug in serum. It's not in cornea. So we don't measure MIC directly on cornea. So that is one limitation. And few surgeons, they believe since we are putting drop directly onto the cornea, the concentration that is achieved may be much higher than the MIC value. And just to supplement this observation, there is a study by Koval et al. Where they took 11 patients of non-healing corneal ulcer. And when they retrospectively evaluated what was the antibiotic sensitivity pattern, they found that 9 of the patients were receiving treatment to which they were sensitive based on the sensitivity pattern. So even if they were we were using sensitive antibiotics, still it didn't respond. So they highlighted that the antibiotic sensitivity, although it may guide your treatment, but it's not that it's always useful. Efficacy, I have already shown you that table. Almost 50% of the cases, the culture may miss the diagnosis completely. And as we are clinicians, there is a study by Dahlgren et al. Where they found that 73% of the time, a cornea specialist can accurately diagnose whether it is a bacterial or fungal or parasitic keratitis based on clinical examination. Similarly, Damon et al. They found that a clinician with fair knowledge can clearly distinguish between bacterial and fungal purely based on clinical observation in 60% of the cases. So why I am highlighting all this point is just to emphasize that even if corneal scraping is not done, it's not that you cannot manage a case of corneal infection or infective keratitis. Even AO came out with this preferred practice pattern in 2019 about which are the cases where corneal scraping may be must. So it's not an indication, or it was not based on any particular study, but they analyzed previous report and they came out with the guideline or advisable. The report suggested that in this condition a corneal scraping is advisable, and the condition include any large corneal ulcer which is more than 2 mm, or any ulcer which is centrally located, any ulcer with associated stromal melting, or if you have already started empirical therapy and the patient is not responding to that, if your patient has any prior history of corneal surgery, or you are seeing a case where there is multiple diffuse stromal infiltrates, or the presentation is atypical, like it suggests some acanthamoeba or maybe fungus or mycobacterial infection. If all these features are there, and you should always scrape the ulcer, or otherwise for small ulcer which is peripherally located, you can still manage with broad spectrum antibiotic. So with this, I'll come to my last slide. So what would be the take home message? Remember, corneal scraping is a sterile procedure. Don't take it as an, because already infection is there, so you can do it without taking all asepsis measures. Don't do that. Do it whenever it is available with you. If you have the facility, always go for it. Suppose you don't have the facility, but the patient is ready to go to some higher center, then always refer the patient if it fulfills all the criteria that is provided by AO guidelines. If you don't have anything, you don't have a setup, neither the patient is willing to go anywhere, trust your clinical skill, and you can treat it at your own setup without going for any referral. But when you are treating it without any microbiology or corneal scraping, then you have to have two datas with you. One is what is the local epidemiological profile, whether bacterial, fungal, or if any particular parasitic keratitis is common in your setup, that you must be aware of. Second, what about the resistant pattern? Just to give you one example, when I joined as a junior resident at RP Center, that time there was a report from our center where they found that 70% of the staph species, they were resistant to ciprofloxacin. So the initial empirical treatment was changed from ciprofloxacin to concentrated cefazolin. So to treat any infection without a proper microbiology report with you, you have to have a data about the local epidemiological pattern of your keratitis. If you have that, then you can always treat it on your own without any corneal scraping or referral to higher center. With this, I would conclude my talk. Thank you again. Thank you, boss and Iskas, for giving me this opportunity, and thank you for your kind attention.
Thank you, Dr. Praful. It was a very nice coverage of the topic. Can you just unshare it? We have with us Professor Namrata Sharma, who has worked extensively in the field of keratitis and in this area. So I would like to have opinion of ma'am. Ma'am, what do you think about any additional point you would like to add, or any specific things you would like to emphasize on this?
I think both the talks were really excellent and covered everything. Dr. Nilesh presented very well, showed a very nice practical video on how to deal with the cases of acute chemical injury. I think it is very important, the points that he highlighted so well, that as soon as a patient of acute chemical injury comes to you, and although in the books it's within 2 weeks, all the studies that we did at RP Center were, within 3 weeks. So as soon as the patient comes within 3 weeks to you, you should not hesitate to give topical steroids, topical citrate, topical acetate, and that slide that he showed you, which is so important for the prescription. Dua's classification has come up, but I feel that it still lacks a very important parameter, and that is ischemia, which it does not take into consideration. And I feel ischemia plays a very important role in healing. So that is something that people have to really work at. And another important thing which I would suggest is amniotic membrane transplantation, more so in moderate to severe burns, not in mild to moderate burns, but when they are kind of grade, I wouldn't say grade 4 with the epithelial defect, and 5 and 6, then amniotic membrane does help in those cases. But I think Nilesh covered almost everything, and there was nothing left uh, apart from the treatment modality that he very beautifully highlighted. Now, regarding the scraping, again, it was covered very well by Dr. Praful Marana, who's mastered this, art, has a ICMR running project, and has a very keen interest in microbial keratitis. I just would like to emphasize that some of the cases you have to take deep scrapes, because you can't, get them superficially, like fungal keratitis. You have to take it deeply, take a deep scrape, even a acanthamoeba, and for that matter, pythium also. Very nicely, he highlighted it is very important to know geographically where are you sitting, because sometimes you have to keep in mind which are the organisms which are common. So geographic location is very important. If you're sitting in North India, it is aspergillus. If you're sitting in South India, it is fusarium. If you're sitting in East India, then again it may be aspergillus. And if you're sitting in Central India, it is a mix of both. So all these centers have reported different organisms. So I think it is very important to highlight on that. And one thing I would like to differ slightly from Praful, that I feel BP knife is a better way of scraping, although we continue to do with a 26 gauge needle, but that is something which should be avoided because it leads to more perforation, especially for people who are not really, handling corneal ulcers day in and day out.
Okay.
Dr. Rishi wants to say something.
We have a question from Dr. Rumta, who wants to know from Dr. Nilesh that after conjunctival sac wash, whether we should prefer drops of antibiotic or ointment of antibiotic. So Dr. Nilesh would like to take up that question.
Should be preservative-free drops.
Yeah. Okay. That's fine. And will it be good to wash the Calde sac and chemical injury with the help of lubricating drops available readily in sterilized form? I guess wash.
I think since
saline and it has to be copious for 30 minutes.
Copious for prolonged period. So I mean, you can't afford it with any lubricant.
Yeah, absolutely.
Wash, I think, is most important. And if there is nothing available with you, even with the clean water, if you wash, that will be done copiously.
Absolutely.
Rajesh, I just had a comment about both vitamin C and citrate. One has to monitor the epithelial healing. It's important to remember that topical ascorbic acid does not penetrate an intact epithelium. So in case the epithelium is healed, you can stop the ascorbic acid because it's not going to work. So that should be emphasized, that ascorbic acid works in chemical injuries only as long as there is an epithelial defect. So the localized scorbusis that exists would have completed itself. So sometimes at 3 weeks, these patients would have completely reepithelized. And those are not the patients where one would persist with these two medications.
Yeah, it should not be continued prolonged after the epithelial.
Yeah.
Okay. So can we have comments from Tityal sir? Sir, are you there? Tityal sir? Okay. So we move on to the next talk now, and we can have further questions and discussion after that. So the next talk is by Dr. Gautam Parmar, and he'll be talking on Descemet's membrane detachment following cataract surgery. Dr. Gautam Parmar, please.
Yes, good evening, everyone. So I would like to share my screen.
Yeah, please.
My screen is not visible here.
Dr. Parmar, first open your presentation and then do the screen share.
Is my screen visible?
No. You first open the presentation and then you go for share screen.
Open the presentation, minimize it.
Yeah.
And then share it.
So Zoom के ऊपर green button होगा share screen का. Zoom window पे.
Sir, it's not coming
up. Have you opened the presentation?
Yes, sir. I have presentation open on my laptop.
Okay, you just minimize it and come to this Zoom screen. Then you go down and there you will have a green button which is showing.
Yeah, green button of share screen is visible.
Click
that.
Sir, उस पे click करिएगा, green button पे click करिएगा.
हाँ, green button is visible.
सर उस पे click करना है सर उसको. एक विंडो खुलेगा और राइट हैंड साइड पे शेयर का बटन होगा ब्लू कलर का, उस पे क्लिक करिएगा.
हाँ, ब्लू कलर का शेयर का बटन है.
सर इस पे क्लिक करिएगा. सर आप शेयर स्क्रीन बटन क्लिक करेंगे ना, एक पॉपअप खुलेगा.
हाँ, पॉपअप खुला है.
राइट हैंड सिस्टम सर उस पे कुछ नहीं करना, उस पे राइट हैंड साइड पे एक शेयर का बटन होगा नीचे ब्लू कलर का, उस पे क्लिक कर.
Button is there. On pressing that share button, the pop-up is opening, allow Zoom to share your screen.
Yes, sir. Yes, sir. Yes, 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 yes.
Okay, then what to do?
अभी वो पॉपअप खुला होगा दोबारा, नहीं तो एक बार शेयर स्क्रीन पे क्लिक कर लीजिए, दोबारा खुलेगा। एक पॉपअप होगा, उस पे राइट हैंड साइड पे ब्लू कलर का बटन होगा, उस पे क्लिक कर दीजिए।
और
Dr.
Gautam, shall we, would you like to check it again or?
Yes. Okay, sir, you should continue. I will check and then
Okay, just check, and meanwhile, move on to the next speaker, and that is Dr. Revati, and she will be talking on post-cataract surgery tunnel infection. Dr. Revati, can you share your screen, please?
Can you see?
Yeah, we can see. Just go to slideshow.
Yeah, can you see now? Yeah.
Yeah, absolutely perfect.
Okay, thank you. Good evening all. So this is a topic which is little away from the previous talks. On introduction, this incidence of post-op endophthalmitis, we know like very well it is reported, but the post-operative wound infection exact incidence is not very clear in the literature. But the endophthalmitis associated with wound abscess or necrosis, the incidence can range from 2.4% to 16%. So that tunnel infections have many unique characteristics compared to other open exposed wound infections, because the tunnel as such, the corneal or sclerocorneal tunnels, they are a little bit different from the regular scleral wounds. They are not simply leaking wounds, they are more dangerously sucking in wounds. They can suck the external factors into the ocular structures. So intraocularly, that can lead on to an infection. The microorganisms can go and sit there as a sequestrated environment, and that will pose many challenge, including the diagnosis, recognition of the problem, and identifying the organism, and also in the management part. So the risk factors, obviously, like it is from the ocular surface, and it's very important to look for the blepharitis or MGD and any other chronic ocular conditions, especially dry eyes and other things, and patients with topical medications for a long time, as in glaucoma medications, we have to be very careful. And systemic immunocompromised conditions like diabetes and atopy is another condition which can be associated with fungal infections. So in these cases, it's very important to first to treat and at least control the ocular surface problem, and also go for a preoperative conjunctival culture, at least for medico-legal purpose also, and also it will give some clue when to go ahead with the surgery. And incision related factors, it's logically like temporal wounds, especially clear corneal wounds, are more prone for infection than the superior one, which are little covered, but temporal wounds are more exposed. And the clear corneal wounds again are more exposed than sclerocorneal. That's why many surgeons prefer, even for a clear corneal, supposed to be clear corneal section, they would like to start their section just beyond the conjunctival insertion, that is the posterior limbal or anterior scleral, so that there will be an extra cover in that area, outer part of the wound. And the source of infection, as already we have seen, probably from ocular surface, and also it can be from contaminated instruments like blades and sutures. More commonly associated organism in this condition is atypical mycobacteria. And contaminated drops also, topical dry drops like local anesthetic agents are known to cause these infections. We have come across few years back in a center from south, a cluster of gram-negative infection occurred due to contaminated topical drops. And of course, in immunocompromised, as already I told, in case of atypical, we can expect more fungal infections. The clinical features is, it's a very challenging condition to recognize immediately because it may take weeks to months to come as a wound infiltrate. Initially, whenever you get a recurrent post-op iritis or uveitis, then you have to keep a eye on the wound and carefully observe it. You can slowly, it will start a small dense area of just a haze, and then gradually it will consolidate into an infiltration. Sometimes early in the course itself, you can see an iris nodule or exudate in the IOL bag also. But many times it will be confined to the internal wound by the time. But what we have to remember, when it is shown in the anterior chamber or the internal lip of the wound, already within the tunnel it has developed into a considerable size. Sometimes it can come out of the scleral part also. And the challenge in identifying the organism, naturally it's a confined area, so it's not easy to just to scrape and get the material. Many times we have to go in and to the internal lip to aspirate the material for culture. And sometimes we may need to go for a corneal biopsy, and very difficult to get the material also for the microbiological workup. And coming to the treatment, again, of course, once we know the organism, accordingly we are going to treat. But the medical management again will be a challenge because in a confined area, your topical drops, very rarely they will reach. So you may need to go for intrastromal injections or intracameral wash. And sometimes you can de-roof, when you take a biopsy, de-roof the tunnel, and then you can go for injections and drops. And in my experience, very rarely this medical management alone will help, as in this case, the upper two slides, where it's a case of aspergillus. Luckily, with the repeated intrastromal injections and oral voriconazole, she responded. But many times, as we wait with the topical medications, it will go into a worsening condition, as you can see here in the bottom two slides. So nowadays, I prefer to go for surgical intervention so that, especially when it is still in the confined area and the periphery, instead of waiting and going into a graft which will cover the visual axis also like this. It's better to go in the earlier stage so that we can remove the material, and also we'll get material for proper microbiological examination. And sometimes we have to combine this with iris nodule. If there is a nodule, a sectoral iridectomy, and we have to carefully expose the IOL bag and carefully watch. Sometimes there will be exudates all around, and then in that case, we have to remove the bag along with the IOL very carefully, as much as possible without disturbing the anterior vitreous face. And again, even after doing a surgical intervention, as I said, if we waited too long, especially certain type of organisms like atypical mycobacteria or Burkholderia, the gram-negative bacteria, you can end up with recurrent infections in the patch graft also. So in this patient, finally, she ended up with a limbus to limbus big graft. Only then we could control the infection. And that is why nowadays I prefer to go for a early surgical intervention. And once it goes to the sclera, it has to be managed with the debridement, cryo application, and sometimes we can go for a wash and cautery also in that area. So, as we know, like even diagnosis, management, everything is a challenge. The prevention will be the best part in this to avoid these tunnel infections, especially. So, a meticulous preparation of the periocular skin, ocular surface, and even before the surgery, day of surgery, to prepare the ocular surface and treat them is very important. And by checking the wound at the end of the surgery, if you have even slightest doubt, never hesitate to go for suturing the wound, and don't feel shy about it. And unless you are very confident about the wound integrity. And also I would many times, always I used to put a drop of viscoelastic over the whole ocular surface, so that surface also will be covered nicely, and also we can paint the outer exposed part of the wound with the another layer of additional layer of barrier. And also application of povidone iodine at the end of the surgery is another useful tactics, and intracameral antibiotics nowadays become almost like a routine practice. So on conclusion, the exposed wounds are better, but tunnel wounds are always a challenge to recognize also. Whenever you get chronic or smoldering inflammation, always keep this mind and also look carefully the wound. And whenever you get a wound infection, and you have to go for at least intrastomal injections and other things. If the medical treatment is not showing any sign of improvement, don't wait too long, go for a surgical intervention, go for a patch graft. That way we can save the globe as well as to, I mean, visual rehabilitation also can be reasonable. Thank you.
Thank you, Dr. Revati, for a very nice coverage of the tunnel infection. We'll have the questions after the next talk. Dr. Gautam, are you ready with your talk? Dr. Gautam, yeah, Dr. Gautam will be presenting on DMD following cataract surgery.
I think in the meantime, let me make a comment on this very nice talk from Dr. Revati. I think, she rightly pointed out tunnel creation is a major predisposing factor for our wound infections. We never had such, things when we're doing a conventional extracapsular surgery. It has come now with the phaco tunnels or SICA tunnel. Whichever case I remember seeing in cornea clinic, most cases were after SICS. It's a larger incision, you damage the limbal vessels, expose the limbal area, no epithelialization sometimes, and a lot of cauterization. So these are important issues which can cause incision site infections. Leaky wounds would cause endophthalmitis, that we all understand, but it normally doesn't cause tunnel infections. Tunnel infections normally are well-sealed wounds, and in fact, this is an area where it can get edematous, because after phaco, why should infection occur? That means the wound has not been managed appropriately. Either there is a collagen which is totally destroyed because of heat generation, or a distortion of that area, which has led into a severe edema in those cases, causing epithelial defect in these cases. So one of the most important investigation in these cases for a better management is to identify where exactly the infection is. It can be the posterior plane, it can be the interface, it can be the anterior to the corneal tunnel. So if you have an anterior segment OCT, which can define sometimes where exactly you are, or it is all the layers may be involved. So if you have anterior involvement, it's easy to manage. You can scrape out, you can sacrifice the anterior tunnel, also use a little glue in those cases. Same holds true for interface infections also. Very difficult to treat. Yes, intrastomal might help in these cases, but sometimes you may have to sacrifice the tunnel in these cases. Otherwise, that will rapidly increase to other adjoining areas or go deeper also and cause very difficult to manage. So most importantly is the malmanagement of wound area, which is called loss of vascularity in that area, and destruction of a collagen tissue, which has led into this infection. And sometimes I've seen multiple sutures also, like people who are training into phaco, they would have around 2.8, 3.2 incisions, and they'll put 4 or 5 sutures, but they struggle to close this wound. That means there were a lot of damage during their phaco. And these are the cases where you can have more chances of infection, apart from the compromised ocular surface and a compromised immune system.
Thank you, sir.
Thank you, sir. It's a very nice discussion. Yes.
Just a couple of comments. Dr. Rajesh, 1 minute, just one comment.
Yeah, please.
My comment was only with respect to the variety of infections, because we've seen even atypical mycobacteria being cultured from there. So I think it's just that duration, and it can occur as acute and even up to 2 months post surgery. So I think that is one thing we've isolated in 2 patients atypical mycobacteria confirmed by backtech and culture. So just to keep that, if it's, and some of them respond to steroids, so people think that it's getting better, but unless you really go down and take the culture, I think it's very difficult to predict how these would, because I think from bacteria, fungus, nocardia, atypical mycobacteria, almost anything can grow in the tunnel.
Absolutely. There are reports of fungal infection as well in the tunnel.
Great point. Anand, it was a nice point because duration is important sometimes. And I personally would feel, the instrumentation which we use sometimes, using a same blade for a multiple cases without having a proper sterilization. And the practice of betadine has changed a lot in our cases, especially now the COVID also, where you're putting betadine for longer period. And such things can cause, damage. But betadine has really helped us to understand the management of ocular surface and decreasing the surface load. And I think we should practice very, very nicely the betadine one.
I think Dr. Revati raised an interesting point in which she mentioned that she would put a drop of betadine after the completion of the case. How many of us actually do that? Pre-op is a no-brainer. I mean, that's an absolute standard of care. But after completing the case, before you would either patch it or leave the eye open for that matter, how many of us actually put in povidone iodine at the end?
I don't think most people will not put it because they may not be sure of their incision may be totally watertight. What happens when you close the case? At that time, it may be watertight, but you are not sure what is going to happen in next 5 minutes. It may be leaky in next 5 minutes, and you still may have a little betadine in a conjunctival sac. But yes, I've seen a surgeon, Dr. Oshika, from Japan. He constantly uses a diluted betadine drop throughout the surgery. Like we put, saline on the eye, they put diluted betadine continuously during surgery also. That may be totally preservative free, I understand. I did ask him, he showed a video in the RP center also. And he said that has been practiced for him for last so many years.
But would that not increase the risk of TAS?
Possible, but in his case, he didn't show anything. But the concentration of betadine has to be absolutely diluted.
Right.
You can't use, 20%, 10%.
Yes, sir. I used to dilute and use, and I do it always. And before putting the betadine, as I mentioned, I put a drop of visco over the ocular surface because, as we know, ocular surface is after the surgery and after so many topical drops, it will be compromised. So I put a drop of visco, which will coat nicely. Then I put a drop of this thing in the cul-de-sac, not near the wound, and that is a diluted one.
Yeah,
I'll keep it in a syringe and put a drop at the end of the.
So what percentage, Dr. Revati, like most of us, we put 5%
from the drop, 5% we take about.
For refractive surgeries during COVID time, people have started using betadine, and that is 1%.
Yeah, it's almost like that. From that 5%, we take in a 5 cc syringe and dilute it. It will come around 1% roughly. That's what I used to use.
Okay. There's a question for you, Dr. Revati. Meanwhile, since we are discussing, there's a question for you, and that is that what is your threshold for doing a patch graft? At what stage, till what time will you wait before you actually go for a patch graft in a case of tunnel infection?
As Dr. Titial mentioned already, like if we can see after 1 or 2 injections, if I catch them very early, then after giving 1 or 2 intrastromal injections, as he mentioned, that's a very nice point. If it is in the anterior part, most probably it might respond. If it starts showing signs of response, maybe like I'll wait for a little more. But if I see it even in the slit lamp, it's more in the interface or already started like a droplet into the anterior chamber hanging, then I'll go for a patch graft immediately.
Okay, thank you. So we move on and we invite Dr. Gautam Parmar for his D&D following cataract surgery.
Yes, sir.
Is it visible now, sir?
Yeah, it's visible. Just go yeah. Fine.
Yeah, thank you so much. And I would like to thank Iskeris for giving me this opportunity. It's always an honor to present on such a very nice platform, sir. So my topic is Descemet's membrane detachment following cataract surgery. So we all know that it's a vision-threatening complication of almost any intraocular surgery, but it is likely to happen with the cataract surgery. And the incidence is variable. It depends on a lot of factors. So it is about 0.04 to 0.5%. But the management is very promising that it merely a good air tamponade will give a success rate up to 90 to 95%. There are various causes and risk factors involved in the development of this. That is shallow anterior chamber. Here I am just showing you a picture. The upper picture is showing a shallow anterior chamber iris coloboma case I operated, and there was not the Descemet's membrane detachment actually, but there is a scooping of the endothelium layer from the Descemet layer. So this is the lining of that scooping. You may visualize this. Second risk factor is suboptimal quality surgical instruments and complicated procedure itself. In lower picture, you can see the Descemet's membrane detachment near the SICS tunnel because of the poor instruments. So, and another that is surgeon factor, that is inadvertent injection of the saline or visco between the stoma and Descemet's membrane while hydration of the wound, and there may be chances of some marginal corneal degeneration may predispose this condition. So the presentation is that the severe corneal edema on the first postoperative day. So we always have a suspicion that whether this edema because of the Descemet's membrane detachment or maybe some other reason like use of excessive phacoenergy near the Descemet's membrane. So the feature of this Descemet detachment corneal edema is that they are usually sharply demarcated. We can have a sharp edges that limits the Descemet membrane detachment, and they usually present at the peripheral location near the ports. So these are the peculiar feature of edema because of the Descemet's membrane detachment. While the edema because of the excessive use of phacoenergy is usually restricted to central and the edges are not well demarcated, but they diffuse. To diagnose the condition, slit lamp have a great help. You can see that the slits, the undulating Descemet's membrane detachment can visible very well on the slit lamp if the corneal clarity is optimal. ASOCT is an excellent tool to delineate. As you can see here, we can see the Descemet's membrane profile in any of the meridia. As you can see here, vertical, horizontal, as well as oblique meridia, and you can see the various the pattern of Descemet's membrane detachment. One thing I would like to highlight here that in the inferior picture, which is showing the section in the vertical meridia, the Descemet's membrane is straight, while in the horizontal meridia it is undulating. So this undulation in the horizontal meridia suggests that the probably damage occur in the horizontal meridia itself, which causes this undulation in the horizontal section. Sometimes a fibrinous reaction can mimic to the Descemet's membrane, but there are some peculiarities of fibrinous reaction that these are not the continuous as the Descemet's membrane detachment. The hyperdensities are broken in between, as well as are not that hyperdense as seen in the Descemet's membrane detachment. So, and in the second picture, you can see it is completely resolved on the next post-op day only with use of the intense steroids. So intervention at the right time is very crucial, though there is reports on the spontaneous reattachment of the Descemet's membrane is available, but the delay in the intervention may lead to delayed visual rehabilitation or fibrosis, wrinkling, or shrinkage of the detached endothelium, detached Descemet's membrane, which further complicate the procedure in the later. Okay, so this is HELP algorithm which may be helpful for deciding the timing for the intervention. Like H is the height of the separation from the stroma, extent is the length of that separation, and involvement of the zone. So most important thing is the zone of involvement. If it is said that if the height is less than 100 micron or length is less than 1 mm and it involved in any zone, we need not to do any surgical intervention. But if height is more and it is involving the central zone, we should intervene and do surgical intervention. And for peripheral, it is not usually needed. So what surgical intervention should we do? The purpose of surgical intervention is reattachment of the detached Descemet's membrane by giving tamponade, either by 100% sterile air, by the pneumo-descemetopexy, or isoexpensyl gases can be used, like 14% perfluoroethane or sulfur hexafluoride, 20%. So this can be used, but I always prefer air because air has a lot of advantages like low cost, less endothelial toxicity. It has faster absorption, so less chances of the sustained tamponade like pupillary block and all. So it is always preferable to use simple air because it is tamponade that is necessary, not the prolonged air or something inside the eye. It is tamponade which can be given only for say 15 to 30 minutes. That is sufficient only. So the challenges while doing Descemet's membrane reposition is because there are huge edema in the cornea. So lot of things which can give you better visibility during surgery. First one is the retroillumination. If you have a facility of retroillumination in microscope, then it is a wonderful and non-invasive technique. You nothing to do, just go to retroillumination. You can use trypan blue also to stain the detached Descemet's membrane because the endothelial surface will not take stain, but the descemetic surface, which is free from the stroma now, will take stain and you will get a good visibility and contrast to that part. You can squeeze the epithelium from the above with the help of any spatula or hydrocannula itself. It will give you some, it will improve visibility also. Or if it is not at all visible, then you can debride the epithelium, which is edematous, and you will get good visibility. Endo-illuminators are also suggested to improve the visibility during the surgery. It can be done in that either topical or local anesthesia. It depends on the surgeon's preference and your patient cooperation and all these things. So some people may use 30 gauge needle inserted through the limbus and inject air inside the eye. And simultaneously, paracentesis can be done. Paracentesis can also be done instead of using a needle. And after that, we put air and we maintain a full chamber airflow till 15 to 30 minutes. That is sufficient only. We need not to make a prolonged 2-3 days tamponade. Otherwise, it will very hazardous to the eye. So air descemetopexy is advisable, and paracentesis, I prefer paracentesis instead of needle because we can remove air very easily by just pressing the lip of that paracentesis. So air removal is easy, as well as this paracentesis can act as behave as a valvular mechanism which maintain the unidirectional flow of air, which produces better air tamponade. So I always advise making a paracentesis. Even it is advisable that we should not make paracentesis or should not insert needle from the point where the Descemet detachment occurs. But I have seen many cases where I use the same port for the entry of the air. The point is that you should proceed your cannula to the other end and start injecting air from that point only. Like here in this line diagram, you can see this air which are coming from other surface opposite end to your your paracentesis site. So this will oppose your Descemet's membrane in right manner. So you need not, sometimes you may need not to make another paracentesis. If you are sure that the main wound is not implicated, you can use main port also. Like I have used many times the same tunnel for the injection of the air. I always use this 26 gauge cannula applied on the 2 ml syringe. So here is the video I'm showing you. First we have to, because these cases may contain some air also, so first we remove the air, injecting blue, trypan blue, wash it. Retro visibility is not good enough even after using retro illumination, so I debride the epithelium. We need not to debride too much of the epithelium, we just restrict it to center part only. And now your hydrojet only you can see, and we can do indirect manipulation through the hydrojets as well as taping. Now you can see this is entry of the air from the opposite end, and you can see Montessori's sign kind of thing, what we use for the DMEC, where we can see the bluish coloration of the cannula because it goes beneath the stained endothelium Descemet's complex. So your color of cannula becomes blue. So this is called Montessori sign, and this can be an indicator that you are in a right plane and you are not injecting your air in the between the Descemet's membrane and stroma.
So time is over 10 minutes.
Okay, I'm just finishing. So here, if the visibility is good enough, only retro illumination works well, like here seen in this picture. Only hydrojet will give you an idea of the free Descemet's membrane, and you can inject air to, okay, as you can see the movements of the Descemet's membrane here, and you can inject and just do ironing in the opposite direction of your detachment. Okay, this is always helpful in squeezing the fluid out. Here is another case where I squeeze the epithelium. So this squeezing will improve to some extent the visibility, and gentle tapping will give you an idea, and then you can inject air just opposite. Your injecting air is very important, the direction of injection, and then ironing in the opposite direction of your detachment. This is another case of tractional Descemet's membrane detachment, old Descemet's membrane detachment where tractions are formed because of the fibrosis. So I put air and I put some visco near the air. I prefer to do it under air and put visco on the port. Now I am using Reversinsky hook to release these tractions. So you can use this Reversinsky in this manner, so to release these tractions from the Descemet's membrane, and then you may use the isoexpansion gases here, because you may sometimes need a prolonged tamponade here. But I am here using gas 100% air only, and it provided good outcome. So these are the outcome. We know that corneal clarity regains within hours. Air absorption, complete air absorption can happen within 3 to 4 days with complete visual restoration. So outcomes are very good. These are the few cases from us. Complication, as you know, that pupillary block or oppositional angle closure is likely to happen if air moves behind the iris. Just one second. Can be avoided by dilatation. If it is still present, we can do acid decompression and synecholysis. So to conclude that it's a serious vision-threatening complication of cataract surgery. Early recognition is crucial in preventing further damage, which may lead to irreversible loss. ASOC is extremely helpful in diagnosing and management planning, and management is very promising with excellent success rate. Thank you so much.
Thank you, Dr. Gautam. It was a very nice overview on Descemet's membrane detachment. This is some. Can you just unshare the slides, please? It's such a common condition that we encounter in our day-to-day practice. Would like to have opinion of some of our panelists. Can we have Dr. Vibhuti opine on this? He is again a very large volume cataract surgeon. He keeps doing that. So how often do you encounter situation wherein you really have to intervene, because many of these DMDs are self-limiting? So can we have your opinion, Dr. Vibhuti?
Not quite often, but yes, if we are not careful, then we can land up into trouble. If there is a descemet detachment in the beginning of surgery, and then if you are not careful while handling those tissue during the whole procedure, then it can extend and it can give you trouble time. At the same time, I had a bad experience once in early days of phacoemulsification when I did a 360-degree of descemet detachment by injecting viscoelastic into that space. So that was one very tricky situation for me. But yes, these things needed to be identified early on and need to be handled with care. Most of the time, multiple instrumentation is the multiple entry and exit that is going to make the difference. So I prefer to have a single entry phacoemulsification most of the time. Try to complete the job which has been assigned to me. And that saves my day. That is the way.
Yeah, that's a wonderful message, that the minimum manipulation will, prevent you from landing into such problems.
Just could I comment?
Uh,
Just a couple of comments,
yeah,
Rajesh.
yeah.
I think it was a very nice series of presentations by Gautam. What I really want to add is that the site of the detachment almost decides how well the outcomes would be. With inferior detachments, you will struggle to really make it stick. So you would sometimes need expansional gas. You may really require to do an inferior PI. And what I would probably strongly suggest in cases where it is recalcitrant, it's not a bad idea to put sutures through and through, 100% nylon bites, maybe a couple to really hold adjustments in place. It's not a bad idea. It works quite well.
Absolutely. In many of these cases, you may have to do even stab incisions in order to drain the fluid as well as do a desmetopexy with gas. And inferior PI is something which is done with extensive DMDs, particularly inferior DMDs. And one point very nicely pointed out by Dr. Gautam was that if in a scrolled DMDs, your direction of gas injection should be opposite that of the scroll, so that it unscrolls the Descemet's membrane and attaches it very well. Dr. Pranav Ranjan, can we have your opinion, sir? You, in your clinical practice, how often do you encounter such situations?
I can remember that. I have had around couple of cases. I precisely remember I had 4 cases in all of descemet detachments. And most of them, all of them probably, they were because of the exaggerated wound hydration that I used to perform to seal the wound. And I could see the detachment there. And all of them, fortunately, with the conservative method of management, air bubble from the opposite side, the very next day, they all recovered. So from that point onwards, wound hydration, I'm very specific about that. I do it in the superficial part. I don't forcibly do it in a forceful manner. It's a gentle wound hydration. And this lesson I have learned.
Thank you. Thank you, sir. So we move on to the next talk, and that is on corneal gluing in perforated corneal ulcers. We have 2 talks related to perforations, small perforations, corneal gluing, and for larger perforations, we will have Singh will be talking on corneal gluing in perforated corneal ulcers.
Shall I share my screen, sir?
Please.
My screen is visible, I guess. Yeah.
Yes, it is visible.
Very good evening, all of you, and I'm thankful to Team Iscaris and Bihar Ophthalmological Society for this opportunity. And I will be talking about role of corneal glues in perforated corneal ulcers. As we all understand, perforated corneal ulcers are ophthalmic emergency, and the primary aim here is to maintain the ocular integrity. Vision comes secondary, and we have multiple options. But we will discuss today tissue adhesive. Tissue adhesives in perforated corneal ulcers can be used in two manners. One as a primary sealant, another along with other biological tissues. And the important point to consider here is the size of perforation and what is the etiopathogenesis of perforation, what is the basic cause behind it. We have mainly two types of tissue adhesive. One is synthetic, the cyanoacrylate glue, which are readily available, less expensive and easy to use, but they are non-biodegradable, they cause foreign body sensation and they induce vascularization. While biological glue, the fibrin glue, they are biocompatible and biodegradable, but their tensile strength is lesser than cyanoacrylate glue. And as they are blood-derived product, there is always a risk of disease transmission. Coming to cyanoacrylate glue, they polymerize rapidly over the corneal surface and the peak bonding strength is seen at 2 minutes. They stop stromal melting by decreasing the polymorpho-neutrophil infiltration. And they have this bacteriostatic property also, particularly against gram-positive bacteria. They are best suited for corneal perforation, which are less than 3 millimeters in diameter, concave in profile, and located away from the limbus. And there are multiple techniques of using them, like direct application with the needle or with different special applicator like Merocell sponge or glue and patch technique. It's always better to do them in operation theater, but in desperate situation, one can do it under slit lamp view also. We need to clean the area first. We need to remove all the dead and necrotic tissue. We need to dry the surface. We have to remove the epithelium from the stroma over which we are going to apply the glue. And important here is not to use this kind of instrument. This is Johnson bud with this cotton part removed. Even if we have to use this, we should cut them sharp and then use it. It's always better to use the back part of the Merocell sponge. Then apply small amount of glue. We don't have to make a big mound here, and then wait for it to get polymerized. It takes nearly 30 to 40 seconds. Once the polymerization is complete, put BCL. This video is from YouTube. Here we are showing the glue and patch technique. As we can see, with the help of this Dermatrifine, we need to make multiple small disc, 3 millimeter size from this non-sticky part of surgical drape. And once these are ready, we need to have little bit of any ophthalmic ointment will do as such like this. We need to touch this with the Merocell sponge, then go and touch the disc, the plastic disc we have prepared. Then dip it gently in the glue, very small amount again. Now bring it to the surface from where we have to apply, dry the surface again, and then put the glue over here. Here, as we will be getting a very smooth superior surface, the foreign body sensation would be lesser here. And this is best suited for ulcers who are, flat in profile. This works well for ulcers who are concave in profile. So both of them have got their own advantage and disadvantage. This needs more instruments. This is one interesting situation which I came across recently. This was one perforated PUK, and we can see as soon as the glue is out of needle, it's getting polymerized. It's out and it's polymerized. It's not allowing any time for us to wait for it. So when I checked the expiry date of this glue, what was written over the box, it was well within the expiry period. But what was printed here, that was already expired. So this is a new learning experience for me also. So this is the post-operative picture of the same patient. The next day, as the patient was doing well, so I just left the glue and the BCL at the place. There comes some special situations also, like if the aqueous is free flowing through the corneal perforation, then we need to have some sort of temporary tamponade there so that the extrusion of glue doesn't happen and the mound doesn't form. So we can put a small air bubble over there. If the iris tissue is plugging the perforation and the AC is collapsed, then we need to reform the AC with viscoelastic material or in small air bubble. We can put a disc of sterile plastic drape, as we showed in the video, over the perforation and then put the glue over it. Or one can go for Dua's technique of placing the double layer of a sterile plastic drape, that is put the drape first, 2 mm drape, then put the glue and then put a larger drape there, that is 3 mm disc, and then put the BCL. That is how it can be managed. Then for larger perforation, although that is going to be the next topic, another technique has been proposed, that is placing the Tangero nylon stitcher as a mesh across the defect and then put the glue over it. Then comes the question when to remove the glue. How to know now is the time. When the eye appears to be relatively quiet, patient is relatively symptom free, and when we gently nudge the BCL margin, and if the glue simply moves with the BCL, then we can remove the glue. That means the epithelialization is complete. Simply remove the BCL, glue usually comes out with that. Next glue we have is the fibrin glue. It has got two important components. One is fibrinogen, another is thrombin, and the idea is to form the fibrin polymer that will stay and stick. We have two commercial available preparation. One is the T-cell, another is the Relicel, and with no financial interest, most of us would agree that T-cell has got a little better quality. And both of them, they come with proper instruction how to prepare them, like mixing blue with white and yellow with red. Similarly, these two will be mixed as is shown here. So preparing the glue is not a big deal. When we compare fibrin glue with cyanoacrylate, then for defect up to 2 millimeter, it is as effective as cyanoacrylate. But for defect between 2 to 3 millimeters, cyanoacrylate has got better tensile strength. Fibrin glue can be used with other biological tissues also, like amniotic membrane graft. It works really well in smaller perforation like 1.5 or 2 mm perforation. We just need to make a plug of amniotic membrane, put it in the perforation, and then put the glue all around it. This is really good for compromised ocular surface, like those cases of rheumatoid arthritis or keratoconjunctivitis sicca. Those cases, they take real long time for epithelialization, and there is always a tendency of glue to fall off. So in those cases, this is really useful. Tennant's patch graft, Namrata ma'am and group, they have published a very good case series of 31 cases where they managed those cases of perforated corneal ulcer with Tennant's patch graft, and the perforation was up to the size of 6 mm. So they used either cyanoacrylate glue for smaller perforation, and for larger perforation, Tennant's along with sutures. Tennant's is advocated because it is an autologous tissue, availability is easier, it causes minimal reaction and vascularization, and it is cost effective. I will just show a very small quick video, and this is a very old video in fact. This was a case of corneal ulcer which healed with fistula formation. As we can see, there is a free flowing aqueous. We just dissected the fibrovascular tissue from the surface with blunt dissection, removed the entire thing, and then we took a small amount of Tennant's, cut it and put it in the perforations, fixed it with the fibrin glue, took amniotic membrane, did a multi-layer amniotic membrane graft, then put another graft here on this area from where we have taken out the fibrovascular tissue, placed it properly, and then took a larger graft and covered the entire area, fixed it with the glue and suture wherever required. And this is the post-operative picture of the same patient. As we can see, the fistula healed really well. So if I have to conclude, if we have to think about the size of perforation, if it is less than 2 to 3 millimeter, tissue adhesives, they work well as a primary sealant. Amniotic membrane graft can be used along with fibrin glue or suture. Tennant's patch graft can be used along with tissue adhesives. For larger perforation, one can go for Tennant's or corneal patch graft along with tissue adhesive or sutures as and when required. Thank you.
Thank you, Dr. Mamta. That was a wonderful presentation. We'll take the questions after the next presentation. I would now like to invite Dr. Anand Parsasarthi, who will be speaking on larger perforations using patient's own tissue to manage. Dr. Anand Parsasarthi, please.
Thank you for inviting me, and it's a pleasure always to be part of the presentation. I would like to thank BOS and the ISCRIS for allowing me to be a part of this. I practice further down south, so I would just modified it just a bit by adding a bit about melts and perforations using the patient's own tissue. I'll start with one patient, 82-year-old patient, operated for a primary pterygium about 15 years back. And the regrowth was noted about 6 years back. She's had recurrent attacks of pain, redness, attended OPD in almost all the major hospitals in Chennai. And whatever she gets, she gets temporary relief with the eye drops that she's using. Now this is how she presents, and if you can make out, there is a very large recurrent pterygium, very broad base, and these are actually quite difficult to treat. And as they come onto the cornea, they create a divot beyond which there is tear film instability, and over a period of time, you get a melt at that specific area where the pseudopterygium is on the cornea. And you can make out the extent is quite in terms of the recurrence is quite large as well. And in an 82-year-old, we were quite hesitant about taking up the patient for surgery. We did a corneal OCT, about 100, 200 microns of the cornea still left. And we decided that we would plan to do a treatment for this patient with recurrent pterygium and corneal thinning. And we decided to do a pterygium excision with a modification called the perfect technique, and a combination with tectonic tenon transplantation. Now, how that works is, in what we call a perfect technique, you have an extended removal of the pterygium followed by an extended conjunctival transplant. And all of this is harvested from the patient. Now, what is this perfect technique? The basic principles are, you're trying to replace the normal limbal stem cells. You have wide excision of the subconjunctival fibroblastic tissue. You include mitomycin, and you also remove the abnormal pterygium cells. Of course, they can be combined with the AMG, but in this patient, we didn't really do it. I'll just mention how it's done. So here we did an excision, and you can make out that the base of the pterygium is quite large and the melt is actually center. This is the harvested tenons. You don't need a very large one. And as I started surgery, being a surgeon, you really don't bother about the small things like fibrin glue. And then once I started surgery, I realized that there is actually a shortage of fibrin glue and they're not ordered it. So I was still scratching my head when we started the surgery. We basically need to smoothen the surface so that the attachment of both the conjunctival graft and the tenons is very good. Now, I'm using a number 15 blade, but you can use a hockey stick, or you can use anything that you're comfortable with. Blunt is better. But as we go further and further, we realize that the fibroblastic tissue is actually grown onto the sclera. Now, this is important, that unless you remove the fibroblastic tissue, you would have a recurrence of the pterygium. So it's important that you actually spend time removing that part. Now, the conjunctival donor, which is like an autograft for pterygium, can be done by a measurement through the superior part of the limbus. So I won't touch upon that, but I would want basically to stress the removal of the subconjunctival fibroblasts, which is important. Unless you do this, you would almost definitely have a recurrence, even with the use of mitomycin. So in this patient, we did a fair amount of dissection going up to the insertion of the recti, and you have to be very careful that you don't touch the rectus, or you don't cut the rectus, because sometimes the fibroblastic tissue and recurrent pterygium can actually surround the rectal muscles, especially on the nasal side, and you have to be very, very careful. You have to make sure that you're not cutting muscle tissue. And this dissection, as you can go up to the caruncle and make sure that you remove all that. Basically, my indication is to make sure that you reach at least the position of where you can see a bit of the orbital fat. Now, this tissue is on the sclera itself, and if you remove this, the adhesion of whatever you put, either a graft or an amniotic membrane, is actually very good. Now, this is the harvested donor conjunctival graft, which we are suturing into place. And the melt is actually not very large, so you can, a 3 by 3 millimeter tenon is actually very good. Now, as I put it, my OT technician tells me that we don't have fibrin glue. Now, what we did is we did a modification by using overlay suture. So we put a cross of suture in a figure of 888 around the tenons. So we just like dab the tenons, and then put an overlay of 2 8 sutures. Now, this works very well because you're not really bothered about compression now, and this absorbs a lot more. The epithelium will not grow under the tenon. Remember that if you have the epithelium growing under the tenon will not take. So you have to make sure the epithelium grows over the tenon, and then the tenon will actually get incorporated into the patient's stroma. So the suturing technique in this is quite standard, but just make sure that you put a cross, a 888 cross, when you're using these. Now, this is how it looks. Sorry. This is how it looks post surgery, and we've now seen the patient almost about 1 year now. Actually, I saw her day before yesterday, and she's actually doing quite well. in terms of the apposition of the graft and also how it looks post-operatively. The advantage is, of course, that your recovery is much faster. This is the suture technique that I used along with the connectable sutures. This is post-suture removal. And now she came, this is early post-op. This is about 4 months post-op. And this was day before yesterday. And you can make out that the tenon graft is actually absorbed very well, and this can be used for perforations, for small perforations. This can also be used for corneal melts, and I found this quite useful. It's almost as if the cornea has not been really touched. This was the OCT. You can see that if you look very carefully, the thicker part of the tenons is actually in the mid stroma, and the epithelium is actually grown over and really filled up the space. So this works really quite well. This is pre-op and about 12 months post-op. Looks as if no surgery has actually been done for this patient. I do use a fair amount of Gunderson flap as an adjunct procedure. It works, and Gunderson is of course an ophthalmologist, because we do get a fair amount of patients who have untreated bullous keratopathy, which come with gram-positive, gram-negative infections, and the Gunderson flap works beautifully well, published in 1956. And if you do it well, you can get actually a view into the AC. This is not for a corneal perforation, but a blind eye with glaucoma. And what you have to really do is to measure the cornea, take a tenon-free flap. And this is important because this really affects the adhesion. You do a 360-degree peritomy and then bring this flap over the cornea. Now this is a fairly forgiving procedure. If you have fibrin glue, it does make it easier, but you can even suture it. In this patient, I've actually had a buttonhole, but it resolves quite well. It's a very forgiving procedure, but it gives a fair amount of relief, and these are some of our patients who've had post-op results. So it is a very elegant procedure, provides options to surgeons when all else is failed. So it's important that you offer these to your patients. It can be used even for HSV melts if you don't have access to corneal tissue. I would, these are some post-op pictures, and this is just to mention that always remember you have the other eye, and this is just an extension of using the patient's own eye. This is a patient with a blind eye in one eye, but the other eye actually was quite normal, but a blind eye. So what we did was, this patient had glaucoma in the other eye and then had lost vision, but a reasonable endothelial cell count. So we did an auto transplant. So we used the other eyes as a donor, and the main eye got a PK with ECC. And basically in a lot of these patients, they respond well if the glaucoma is controlled. All of them actually see quite well. So the other eye can be a source of corneal tissue as well. You can also use limbus from the other eye for SLED like we use. And post-op endothelial cell count in this patient is actually quite good. Just to show that you can do it, we've got almost a series of 6 patients who we've done an auto transplant using the blind donor eye with a clear cornea as a donor for the other eye, and a lot of them actually do quite well with reasonable amounts of visual acuity in
1
these
minute
patients.
left.
Most of them do well. So just to conclude, that last part is about lamellar autopatch, published by Dr. Tityal, Dr. Namrata, Rajesh, about using the same patient's cornea. In small perforations like this, you can actually create a flap and flip it and close the corneal perforations. I think it would have been a nice video if I had it. Just to tell you that there are multiple options for using the patient's own tissue. You just have to be aware and be innovative. I think this does give you a fair amount of options. Thank you so much for your attention.
Thank you, Dr. Parthasarathy. I'd like to request Dr. Rajesh to continue with the discussion, please.
That was really wonderful to see all those cases, and I remember the intralamellar auto patch that was described by Professor Tityal long back, and I was part of that study, that paper actually. So that was done for the lamellar surgeries, and in lamellar surgeries, if you have a small perforation, sir had created a small flap. Sir, would like to have your opinion on that. It's a long time back you had done.
That came up before all these, lamellar corneal tissues are being put nowadays as inlays.
Yeah, it was a
That was
2002 presentation. I could not find a video anywhere for that.
after that we could not repeat that. It's a different type of cases. Once you have a perforation which are paracentral, so we made a flap from the from the cornea reflected back onto that perforation. So that was the intralamellar creation of patch. So that was a good idea. But now we have so much of tissue available. You can use those tissue in those areas.
Yeah.
So there are the ideas to have a patient own tissue to cover that perforation.
Right.
But it was meant for a paracentral or a peripheral perforations.
Right. Yeah, but the concept can be extended for melts like the picture I showed, where you have
Yeah,
HSC
yeah,
melts,
yeah,
you can
yeah.
take the
Absolutely.
peripheral.
Absolutely. We have Dr. Rakhi, who is working at IGIMS Patna, RIO. And Rakhi, you must have faced a lot of difficulties during this COVID time in having tissues. And so how often you could employ the techniques that were presented by Dr. Mamta and Dr. Anand for, by using glue in managing these perforations?
Yes, exactly. I wanted to share the same thing that in the COVID time, when there was a scarcity of the donor tissue, we had used a lot of time this Tenon's graft and glue even for the larger perforation up to 4 or 5 millimeters, and found a very good results. So these are two things in cases of PUK or a sterile perforation, SJS, or severe dry eye, or even in infective keratitis, we use many times glue, cyanoacrylate glue, and tenons with glue, tenons, suture tenons with BCL, and at least we could save those eye, and those eyes actually resulted in this thing, adrenal glaucoma, and need optical PK for sure. But these was actually the procedures which restore the ocular integrity for the time being.
I actually was with a fellow from Indonesia during my fellowship in Singapore, and they use fascia lata because you can get a fair amount of. There's no restriction. Fascia lata you can get 9 millimeter, 10 millimeter grafts. So they actually do fascia lata from the thigh, and they in case because in Muslim countries the donor rates are very very low, so they actually use fascia lata as well as one donor tissue.
That's another innovative thing, using fish letter for cornea. I mean, it has been used for sling procedures in ptosis, but yes, I mean, this is something which has not been very often used. Prabhakar is one of our residents, ex-residents, and he's also practicing cornea. Prabhakar, in your experience, what do you think? What is the current status in terms of getting the cornea, and how do you manage these perforations? You must have done it.
Yes, sir. Thank you so much, sir. And it's really wonderful, and I feel privileged that I'm sitting amidst my teachers, and I have the opportunity to gain lot many things again at this platform. So thanks a lot, sir. And as far as corneal perforation and managing it with doing tissue adhesive application and BCL, yes, we are using we are actually managing these kind of patients wherein we are using tissue adhesive. And one thing that I would like to add is, like, normally what we do is we debride the epithelium all around the perforation. So what I personally do is, or I have seen a few of my seniors, like, they just revert it back. I mean, reflect it back. The debrided epithelium, they just reflect it back onto the exposed, iris tissue, rather putting, tissue adhesive directly onto the iris tissue. They are preferably we put it onto the the epithelium, the debrided corneal epithelium that we have put over the iris. This prevents the extensive or exuberant inflammation that we usually see post-operatively if we have put it over the iris tissue. So do BCL as far as the size of the perforation is less than 3 mm or up to 3 mm works really well. My experience with Tenon's patch graft is very limited, sir. So far, I have done hardly 5 cases with Tenon's patch graft, so not too much of experience. But yeah, all these cases are really doing well.
Very nicely said, Prabhakar, because these glues, all these glue can cause severe reaction if you put it on iris tissue. So it's always better to release the iris, inject air into the anterior chamber so that this glue doesn't come in contact with the iris tissue. Otherwise, there will be fulminant reaction. But Rishi, you would say something on this?
No, I think I was just enjoying the last two talks and how they've innovatively handled these perforations. And like I think Mamta showed in one of her slides, there are many ways to treat the same side of perforation. It just depends on what's available to you at that given point of time. So I think the use of a contact lens should always be emphasized in these patients. Once you've done the completion of the work, you must put a lens on top. It is something that, as well as, of course, using conventional approaches, and Anand was giving us all the conventional approaches. So tassorrhaphy is one of them, where in these patients, one can actually close down part of the palpebral aperture to give the tectonic support. That can also work very well in these patients.
Sir Tityal sir?
I think both Dr. Mamta and Anand has given us a wide range of cases where we can have all the alternatives. As we discussed, apart from the glue, the substances which needs to be used are slightly larger perforations, in which I think tenant tissue has become one of the most commonly used, being inert and doesn't incite vascularization, and it can be available in a large amount also, without causing any damage to the area from area you take these tenant tissue. Otherwise, glue has been a major, I think, OPD-based procedure nowadays for our corneal surgeons, and gives you a lot of opportunity to do it in a many cases. I have seen patients I had one patient referred by Dr. Rishi only, where he had put a glue in a patient who had an intax and had a leaking area, and glue was applied. It took long time, but ultimately it healed. So that is a savior for corneal small perforations. The only difficult area which I feel is cases with fistula. There, it's very difficult to take care with the closure which is going to do it, unless you take out the epithelial coating from the fistula or you remove the fistular tract itself. So those cases may require, in fact, a small patch graft, because you have to take out the entire fistulous tract also. So those cases behave little differently than the perforation which you have shown us with microvalvular keratitis or post-trauma or post-melt. They're different than a patient like a coronary artery scar where you have a fistula. Those patient has to be tackled in little differently. The other thing which Prabhakar was talking about, I was not sure putting a epithelium, scraped epithelium back onto the iris surface, then putting a glue on that, because epithelium per se can be very inflammatory also, because they incite inflammation, and anything over the iris, it can create a real inflammation and cause uveitis, and entire thing can get still attached. Instead of that, I'll prefer a inner tissue, like Mamta was talking about, putting your plastic drape as a scaffold. Maybe a better idea in those cases.
Yes.
So I think patients who have a severe dry eye and those who have a lot of autoimmune involvement, like those coming out of a arthritis or a Stevens-Johnson, they are the ones who you may have to have multiple approaches, where one approach may not work, and you may have to then use one and then the second and the third kind of approach. And when I was talking about tassorrhaphy, I was actually talking about patients like that, where it's unbelievable how that tectonic support can sometimes save a recurrence of the perforation.
That is true. I think Rishi has raised a nice point. Like, all these cases would require a very nice, a thorough investigation to pick up what is the underlying disorder or disease. And apart from putting a glue or a patch in these cases, you have to control the systemic disease very nicely. And that is one of the most important part in a patient with PUK or a peripheral perforations, a patient with the immunocompromised situations. We should not forget that part. And many cases may have infections also. The infection has to be tackled first, along with the whatever patch you are doing in these cases.
Dr. Vibhuti, you would like to say something?
I want to ask one question regarding descemet detachment. We talked about curled off descemet detachment where there is attachment. Anything about free floating descemet detachment where already the complete detachment has occurred? These usually are very small kind of detachments. What to be done? So, Tityal sir.
I think there the experience of endothelial keratoplasty people like DMEC. Now, if you have free floating means it has no attachment to any areas, so it has to be treated like a case like a DMEC. But I understand such cases, if it is post cataract surgery, you still may have some area which may be still attached, or there may be some sort of inflammation, and it should be picked up very, very fast and should be resolved immediately. What difficulty we have in these cases, what Dr. Gautam also talking about, if you have large detachment, sometimes your entire detachment may be lying over the iris surface, and with the microscope, it's very difficult to pick up where you are. You may be over the detachment membrane, or you may be underneath the detachment membrane. And he nicely showed the staining. Staining might help you that your needle is underneath the membrane as such. But some cases you can tackle with the little bit of air bubble inside. Sometimes you do have an air bubble that can give you an idea where exactly your bubble. And if you inject another bubble, so they can be a double bubble. So that's a clear indication that you are either over or underneath. But as Anand was talking about, if you have a large detachment which is not resolving, suturing is the best way to handle, and require multiple sutures in the different areas and cause a less stress related folds in the detachment membrane. And if you have access to a good microscope with intraoperative OCTs, that can really give you the area of detachment, attachment type or quality, and subsequently you can titrate which area you want to tackle. There may be a scroll, you can see very clearly on the table. But I can understand cases which come after a very long time. Sometimes these patients might come after 2-3 months of cataract surgery. Cornea may be totally edematous. Those cases will be really difficult as such. Even the epithelial debridement may not clear the cornea. There, IOCT or a handheld OCT, if you have access to, would give you a nice assessment, or even an anti-segment OCT will give you a good idea how to tackle those cases. But I understand large detachment, recalcitrant suturing may be the option apart from doing gas tamponade in these cases.
I guess IOST is really helpful in recalcitrant kind of and tough kind of DMDs, wherein you can be absolutely sure on the table that the desmoid membrane has attached. Otherwise, sometimes even after putting the gas, sometimes there is a small fold left or some detached area left. So yes, IOST is a good tool in those cases.
Positioning of the patient is also important after we put the air bubble.
Perfect, all right. Yes.
Yeah, and sometimes when you are putting gas and filling it whole, then in that case, a small inferior PI helps in these cases, because otherwise you can have a very bad pupillary block. So I think Rajiv has joined back, and Rajiv, we were discussing about the desmoid membrane and the glues in perforations. Your comment on those patients?
I'm sorry I got cut out because of the net, but I believe we had a very nice discussion in one of the Iskeris symposiums about desmoid membrane detachment, especially the ones which have scrolled, and we had talked about an ab interno and an externo approach to both the situations. And as for the glue, I don't know what has been last said about that, so it's a little difficult for me to comment right now. Maybe I can
You can give your expertise.
No, you can give your own opinion, Rajiv.
Glue works very well, but the most important thing I would advise for people who are using glue, cyanoacrylate glue, would be to have a good area of epithelial debridement around the area which you're going to glue. Otherwise, the glue just slips off. The second controversy about glue is that do we actually wait for the glue to dislodge on its own, or do we wait for, actually take it off after some time? And this has been a major discussion in one of the US-based forums on corneal gluing. My take, some people said that you can take it out after about 6 to 8 weeks, but my take on this, the moment you take it off, there's a chance that the perforation will recur, and I dare not do it. So that's kind of my take. But the most important thing, initial cases, I did have loss of glue because I did not do a good amount of epithelial removal around the edges of the perforation. And an interesting thing is that if you have a full thickness perforation, and what would you do about that case? I would say put in a bit of pin-ons or cons, put in the glue, put in air. So that also helps in certain cases, in difficult cases.
Thank you, Rajiv. It was a wonderful session, and I would like to thank you all and request if there are no further comments, then we would like to have the concluding remarks from the Chairman Scientific Committee of BOSS, Dr. Satyajit Sinha.
Thank you so much, Dr. Rajesh. We are deeply indebted to Professor Jeevan Tityal sir, who was there with us throughout the session. We are really very grateful to you, sir, for your valuable comments and your throughout this meeting you were there, sir. We are really blessed to have you with us, sir. I would also like to thank Professor Rajesh Sinha, who helped me formulate this program, who brought together all the speakers, the panelists, and everybody, and designed the whole program. He is from Bihar, and we took this liberty of troubling him to this extent, and he did so much for us. We are really grateful to you, Dr. Rajesh, for all the help that you have given in bringing this webinar together. We are very grateful to Professor Namrata Sharma, who also joined us earlier. We are very grateful to Dr. Milind, our president, who was there, but now he is traveling. We are very grateful to you, Dr. Rishi Mohan, sir, who gave us so much time today evening for this BOS Escris webinar. And I don't need to thank, but Nilesh and Vibhuti, our secretary and treasurer, who were there along with us. We are very grateful to them. They are always very supportive of this scientific programs which are there in the Bihar Ophthalmological Society. We are very grateful to Dr. Rajiv Mukherjee. We are very grateful to Dr. Rakhi and Dr. Prabhakar for their valuable comments. We are very grateful to Dr. Pranav Ranjan, Dr. Deepak Kumar, Dr. Gautam, and Dr. Ajay Sinha for their presence. I would in particular like to thank Dr. Nilesh Mohan for the amazing presentation that he made. I'd like to thank Dr. Prafulla, Dr. Gautam, Dr. Revati, Dr. Mamta, and Dr. Anand for the wonderful presentations that they made. I would like to thank Cipla Pharmaceuticals for sponsoring this program, and more. And I'm very grateful to Sunil ji from Zadio Tech, who has done a wonderful professional management of this whole webinar, and he is always very supportive of our Bihar Ophthalmological Society programs. A very big thank you. A large number of viewers were there for this program, as I have been updated, and I'm very grateful to all the speakers, panelists, and TTL sir in particular for this amazing webinar and presence and comments. And thank you so much to everybody for bringing this all together. Thank you so much. Good night, and thank you.
Thank you to Satyajit also.
Yeah, thank you, Satyajit and the BOS.
Thank you so much. Thank you.
BOS, yes.
Thank you, everyone. Good night.
Thank you.
everyone.
Bye. Good night.
Good night, everyone.
Night. Thank you.
Thank you.